So what exactly is hemophilia?
So hemophilia is a blood disorder. And it's a genetic blood disorder. So they are mostly inherited. So it's passed on from one generation to the other. So it's a genetic blood disorder in which the body cannot form a blood clot because it lacks the clotting factor, it lacks the protein that the body needs to form a blood clot. So the consequences or the manifestations of bleeding disorders are many, and it starts right from the newborn period. So in a newborn who has prolonged bleeding from the umbilical cord stump, that's a red flag. Post-circumcision bleed, in fact, is one of the commonest presentations. So they take that baby boy to do circumcision, they go back home, they are rushing back to the hospital because the baby will just not stop bleeding. That's a red flag. Then in childhood, as the child starts to crawl, first you will see bruises everywhere, especially at the points of pressures where they crawl. You start to see lots of bruises. And sometimes the family or the caregiver may even be accused of abuse without evaluating for a bleeding disorder. But they just see a lot of bruises. And then if you also have a toddler, an infant who is refusing to use a limb, you need to start suspecting, is there a bleed into that?
So with us today, we have Professor Titilope Adeyemo. She's a consultant hematologist. She's the head of the Department of Hematology and Blood Transfusion. And also, most importantly, she's the director of the Hemophilia Treatment Program here in youth. And I think there's nobody else that we should be our guest speaking on such an important topic today. You are welcome, ma'am.
Thank you. It's a pleasure to be with you today.
It's lovely to see you today because you're Titilope and Titilayo, the two
Awesome.
titis.
Yeah, the two titis.
All right. So, but before we get into hemophilia, can you just introduce yourself to the audience a little and why you chose this field you did?
Ah. Well, you said it. I am Titi Adeyemo, consultant hematologist, a mother of 3, a wife of a professor of oral and maxillofacial surgery. I've been working in LUTH for several decades. And I'm just happy doing what I do, making impact on the lives of people who have blood disorders.
Okay. All right. Thank you. So, for our listeners who may not know what, when you say blood disorders, and today, particularly because today is World Haemophilia Day, can you just give them a run through into what blood disorders are and what hemophilia specifically is?
Okay, so blood disorders are diseases of blood. You know, that very important red liquid that flows through our body that delivers oxygen and nutrients to every single cell in the human body. So blood is important. And then when it has diseases, then it becomes a problem. It becomes a problem of all body parts. So unlike some specialties that it may just be specialized to the bones, we are specialized to all body parts because blood flows everywhere. And there are several types of blood disorders. A lot of them are inherited, genetic, and a lot of them are acquired. Unfortunately, the acquired ones are usually the blood cancers. But the inherited ones too are also chronic blood disorders because most people are born with them, and then they have to live the rest of their life with that disorder, struggling to live with that disorder. So we have sickle cell disease, which is one of the inherited ones. We also have hemophilia, which we are going to talk about today, which is one of the inherited blood disorders.
So, what exactly is hemophilia?
So hemophilia is a blood disorder. And it's a genetic blood disorder. So they are mostly inherited. So it's passed on from one generation to the other. And though we also have some spontaneously spontaneous hemophilia,
Really?
where we just can't trace the family history, and the mutation just happens spontaneously in the generation, and then becomes a transmitted diseases going forward from there. So it's a genetic blood disorder in which the body cannot form a blood clot because it lacks a clotting factor. It lacks a protein that the body needs to form a blood clot. So when we all get injured, within seconds, the blood will form what we call a primary plug, a primary platelet plug. That happens within 3 seconds in an attempt to stop the blood loss and initiate healing. And then a few minutes after that, we now have what we call the real clot, the real blood clot, which is like a condensation of several blood proteins to block the site of injury so that we stop bleeding and then we can initiate healing. But there are some people who lack those proteins that you need to form those blood clots. So once they get injured, they now have a prolonged bleeding because it takes time for them to eventually form that blood clot. So that's basically what hemophilia is. Inability to form blood clots, and that can become a real problem.
All right. So, but like with most illnesses, you mentioned sickle cell disorder. You know, there are variations and there are different severities. Is it the same thing with hemophilia? Are there variations of hemophilia, and are there different severities of hemophilia?
Sure. There are different types of hemophilia, but the two major ones are what we call hemophilia A, in which the missing clotting factor is factor 8, and then hemophilia B, in which the missing clotting factor is factor 9. There's also another important bleeding disorder called von Willebrand, and we need to also talk about it because that's pretty common, and the diagnosis is often missed, and then it causes also a lot of issues. And then people can also have a hemophilia A or hemophilia B or even Willebrand, and then they can have a mild disease. They can have a moderate disease, and they can have a severe phenotype. Unfortunately, the cases we see mostly in this part of the world are the severe ones, because those are the ones that will manifest with spontaneous bleed. Without any injury, they bleed, and they can bleed into any body organs. Yes, because they lack this protein, when they get injured, they have prolonged bleed. But that's just a manifestation. There is also several severe bleeds internally. You won't see a clot, but they are bleeding into the muscles, they are bleeding into the cavities, they are bleeding into organs, they are bleeding into joints, and people can manifest any of this presentation. So for those with severe, those are the ones that will bleed spontaneously without any injury. They will bleed into the joints, they will bleed into the body organs. So because of this, those are the ones we tend to see. For those that have moderate hemophilia, they will often bleed following a challenge, following a trauma. So it's only when they get injured that they bleed, and the bleeding is not stopping. So they will present, oh, this bleeding is going on and on and on. So they will also present. But most commonly, we see often the severes because they bleed spontaneously. For those that are mild, they don't even present at all. Okay, because yes, they have prolonged bleeding, but over time, with time, the bleeding will stop. So they dismiss it until they're also challenged by a dental procedure.
Okay.
And then they don't stop bleeding. They get challenged by a surgery or a trauma, then they don't stop bleeding. Then people will start to question what is going on here. So those are the phenotypes that we have, the different severities that we have. For the von Willebrand, which is one of the bleeding disorder that we must talk about, because we always tend to associate hemophilia with males. It's a myth that it's only males that are affected. Yes, females are often carriers, but they can also be affected. And we tend to miss a lot of diagnoses in the girls, in the women and the girls. And it's one of the major contributors to postpartum hemorrhage. So we need to talk about bleeding disorders in women and girls. And this is also where hemophilia, von Willebrand's disease comes in. So a lot of, because von Willebrand is even more common than the hemophilia. The hemophilia will say you find it in 1 in 10,000.
Yeah.
For Willebrand, it's even more. 1 in 1,000.
Okay. 1 in 1.
Yeah. A lot of people will be mild.
Mm-hmm.
A lot of people will be mild, but they still have a bleeding disorder and they will still face complications when they are heavily challenged. For example, for women and girls,
Yeah.
during pregnancy and the peripartum period, that's a serious challenge for them. And then they manifest with postpartum hemorrhage. And postpartum hemorrhage is one of the leading causes of maternal mortality in Nigeria. So we need to start speaking a lot about bleeding disorders in women and girls.
Okay, so let me just ask, so what is the major difference between hemophilia and von Willebrand? What is the major difference? I know for the patients, it might not be a huge deal, but I mean, if you're in the hospital, how do you know, okay, this is a person presenting with hemophilia and this person has something else?
I would not want to emphasize on that difference because the manifestation is the same, a bleeding disorder.
Okay.
The difference is just the missing factor.
Okay.
Okay, for hemophilia A, you lack factor 8. For hemophilia B, you lack factor 9.
9.
For von Willebrand's disease, you lack von Willebrand factor, which is also one of the clotting proteins that is needed. So the manifestation is still a bleeding disorder. Every menstrual blood flow in ladies, and it's often dismissed. Oh, it's a family history, we bleed every during our menses. That may be a red flag for a bleeding disorder.
Okay, thank you very much. That leads me to symptoms. And you've already, I think, mentioned one of the symptoms already, in the sense that bleeding, like you say, it's so common amongst women. Oh, I bleed heavily. And then most everybody like, oh, do you have a fibroid? And that's the first thing. And interesting doesn't have a fibroid. So it's probably just, it runs in the family. Her father mom used to bleed and I bleed for 7 days, all of that. So what are the symptoms that people should watch out for? And, think about maybe when they go and see their doctors that this is what's happening to me.
So the consequences or the manifestations of bleeding disorders are many. And it starts right from the newborn period. So in a newborn who has prolonged bleeding from the umbilical stump cord, from the umbilical cord stump, that's a red flag. Okay, the umbilical cord has been cut, the stump kept oozing and oozing for days, they keep cleaning with spirit, that's a red flag. Post-circumcision bleed, in fact, it's one of the commonest presentation. So they take that baby boy to do circumcision, they go back home, they are rushing back to the hospital because the baby will just not stop bleeding. That's a red flag. And that baby should be screened for a bleeding disorder. Then in childhood, as the child starts to crawl, they start to use their joints, but they start to bleed into the joints. First, you will see bruises everywhere, especially at the points of pressures where they crawl. You start to see a lot of bruise. And sometimes the family or the caregiver may even be accused of abuse without evaluating for a bleeding disorder. But they just see a lot of bruise and they think it's either the child care services is abusing the child or the parents are being careless and so on. So that's the presentation for childhood. And then if you also have a toddler, an infant who is refusing to use a limb, you need to start suspecting, is there a bleed into that prolonged bleeding from the nose? Children are very active, they play around a lot, they're going to get injured. A lot of them will dismiss because they will naturally heal and stop bleeding. But you see a child who bleeds from the nose for 15 minutes following a play. You need to start suspecting a bleeding disorder and should get that child screened. And then frequent bleeds into joints. And then the joint starts to swell, starts to become disabled, starts to become disfigured. They need to think of a bleeding disorder. And then, as I also said, they can bleed into any body parts. Okay, so if you presentation of a swelling in any parts of the body for days with pain, you need to suspect a bleeding tendency, especially if it is frequent and recurrent. And in women and girls, prolonged not even prolonged, every menstrual blood flow. They use a pad, it's soaked within minutes. They have to change, and they have to do that several times a day. And they say, oh, my mom does it. It's in our family. My sister also experiences that. That's a red flag for a bleeding disorder. And that would be a patient with a high risk for postpartum hemorrhage, needs to be evaluated even before they go into that challenging period.
This is quite interesting. Like you said, most times you think about hemophilia, you think of men, but you're bringing a new dimension to it when you're talking about women and the fact that you bleed every month and the risk is quite high for women. All right. So, talking of symptoms now, let's move to the diagnosis. The theme for this year's Hemophilia Day is diagnosis, the first step to care. So, what are the points at which the patient coming in for diagnosis? Why is it important to diagnose APG? The patient comes in.
Yeah, because of misdiagnosis and the consequences of misdiagnosis. Let me give you some staggering statistics. Considering a population of 230 million Nigerians, by prevalence statistics, WHO prevalence statistics, we should expect about 1 in 10,000 Nigerians to have hemophilia, and so that would translate to about 20,000 to 24,000 Nigerians being diagnosed. But we have less than 1,000 in the national registry. So that's about 6% of Nigerians who have hemophilia are recognized as hemophilia and are in the national registry. Some 95% are out there, undiagnosed and suffering. And it's also interesting that even in the health system, there's a lot of misdiagnosis. Doctors are missing the diagnosis. Healthcare workers are missing the diagnosis. They are not thinking hemophilia when they see a child present with a swollen ankle or a swollen knee. And even when sometimes when they give the history of prolonged post circumcision bleeds or bruising when the child started to crawl, they still don't think bleeding. I've encountered patients that's presented with typical presentation of a swollen knee. And the healthcare worker thinks it's septic arthritis, and they are treating for septic arthritis. And the difference is the treatment is totally different. So missed diagnosis means missed treatment, and the consequences can be quite debilitating. Because no treatment means that you can prevent the frequent bleed. The hemophilia patients we can't prevent those complications. And the complications can be quite devastating. If you don't diagnose, you don't treat, you don't prevent joint diseases. Because frequent bleeds into the joint would result in chronic joint disease, what we call hematologist. A lot of pain. So they live with pain. They live with disabilities because frequent chronic joint diseases result in joint deformities, and eventually some of them will become wheelchair bound. Those are the missed opportunities to prevent those complications when we don't diagnose. And in women and girls, I will go back to that again. If you don't diagnose them, they go into labor, they get postpartum hemorrhage, and the statistics have shown that 57,000 women die from birth-related death every year. About 30 to 40% of that is from postpartum hemorrhage. These are preventable deaths. So if a woman has been diagnosed to have a bleeding disorder and she gets all the required support peripartum to prevent that loss of life. So you can imagine the losses we are experiencing because of misdiagnosis.
And it takes me back to the data you shared earlier when you said you have only about 1,000 people on the registry. So you have 95% of undiagnosed walking about. How many of them are women, and how many of them will succumb
to postpartum hemorrhage?
Because we don't,
So we need to bridge that gap. We need to start talking. And for a long time, we have put emphasis on the male hemophilia because they are the most, typically affected. But women are also suffering bleeding disorder in silence. And we need to start talking about it more to bridge that gap.
All right. So the question now is, when we talk about the importance of diagnosis, the question for me now is, what are our challenges with diagnosis? Is it the facilities? Is it the structures? Is it the education? What are the challenges?
Numerous, variable, but I'll start with the lack of awareness. I said it a moment ago that even within the S system, there's severe lack of awareness about bleeding disorders. Okay, doctors just don't think about it. So we need to start suspecting it more. And then in the community, when people present with some of those symptoms I talked about, it just starts to crawl and starts having bruises.
Yeah.
And then later on start having swollen knees and swollen joints. They think about witchcraft. They think about something spiritual. And the hospital is not going to be their first point of call. So you can imagine a well child who looks well, has not had problems, and then now starts to cry and start developing bumps. The family can't see anything around this. So they think, oh, this is spiritual. Somebody has thrown arrow to my child. And then the hospital is not going to be their first point of call. So they go to spiritual houses, they go to traditional healers, and then they complicate matters because diagnosis will continue to be missed. So that is number one, lack of awareness among the healthcare workers and among the general public. So that is why we now have the World Haemophilia Day. The WHO has recognized that, yes, then we need to talk more about this, recognize a day, and make a lot of noise about it and start bringing attention to bleeding disorders among people. Then, lack of facilities. And here with 230 million Nigerians have how many hemophilia treatment centers central hemophilia treatment programs in Nigeria? Maybe about 15. And all these 15 are concentrated at the tertiary teaching hospitals. What's the population of people that gets to these hospitals? So a lot of people are not getting the care. So they go to general hospitals where they'll start treating for septic arthritis. Sometimes they won't take them to the theater to go and open up, which is contraindicated. It's not a treatment you want to do. So mistreatment. So the facilities are also, even in these teaching hospitals, the facilities to diagnose it's not readily available. Okay, the tests, which is called factor assay, to confirm the diagnosis, to confirm the suspicion of a bleeding disorder, is expensive. People have to pay out of pocket. Not so many facilities are offering these tests. In fact, apart from, I can count the number of facilities that offer this test in Nigeria in one hand. So people struggle to get diagnosed. I've seen people who have gone from health facilities to another before they eventually get help to be diagnosed. So we have a problem with health facility being able to diagnose. And then because they also have to pay out of pockets, it's also an expensive test. So we are missing this diagnosis, and hopefully we will start to close it with some of the policies the government is putting in place and with some of the efforts organizations like the Hemophilia Foundation of Nigeria is making to close that gap.
15 treatment
Hemophilia treatment
centers in the country, and like I said, it was situated in urban areas. We wonder what's going on in the rural.
Exactly. Where they are doing a lot of circumcisions. People are having prolonged circumcision bleed. Those opportunities are missed.
And then, the family will say that the abiku in the family.
And beyond that, the other consequences of chronic morbidity. Somebody who's bled repeatedly into joints, develop a chronic joint diseases, miss a lot of schools, lives in chronic pain, and then eventually is wheelchair bound. And the social support is not very strong for people with disabilities in Nigeria.
It's
and these are preventable disabilities. if you make the diagnosis and they get the preventive treatment to prevent those complications.
So we talk about diagnosis, yeah, but now we'll pivot to care and treatment because you've talked about the fact that diagnosis is expensive. What about the care?
Yeah, even more expensive.
So you see why people are sometimes they be afraid to come out.
Even more expensive, but there is all. Because we have what we call the World Federation of Haemophilia. Okay, they have come to recognize that this is a rare disorder, this is a neglected disorder. There are some people who have this disorder. We need to come together to support. And with the World Federation of Haemophilia, we now have the national member organization. So every country is supposed to pull together people, stakeholders, people living with hemophilia, their caregivers, parents, support, friends together to form national member organization. So we have the Hemophilia Foundation of Nigeria, which has been fantastic in supporting people with hemophilia. Because through the HFN, we can source for treatment donation or treatment support from the World Federation of Haemophilia. Know that the treatment is expensive. A 10-kilogram child to get treatment would need about 250 IU, 250 international units of clotting factor concentrate. Each unit is about $2. So we are talking about $500 per treatment, which may be required 2 or 3 times a day for several days.
I'm sorry. So you need $500 per treatment.
Per treatment. For that, for a baby, a 10
kilogram baby, and it's per treatment, and that treatment is one out of the 3 they're supposed to take for the day.
Yeah, they need 2 or 3 treatments.
So you're averaging $1,500 a day.
True.
And then if they're doing
maybe several days of treatment.
So minimum we're looking at anything from 4,000.
And interestingly, the standard of care now is that don't even do treatment.
Oh, wow.
Do prophylaxis.
Okay.
You already know they lack these factors. Why wait for a bleed? Just give them these factor replacements every day or every other day so that they don't even suffer a bleed. So a 10-kilogram baby would need to have a factor infusion 3 times a week, about 500 international unit. So that's about $1,500
a week.
No. Yeah, $8,500 a week.
For how long? What's our minimum wage?
Those are the challenges of treatment of patients with hemophilia. But thankfully, we have the World Federation of Haemophilia. Okay, the world president is a non-hemophilia himself. He's in his 60s. He's lived a relatively good life. So they have come to understand that people with hemophilia are going to need this support. They are not going to be able to afford these treatments on their own. So there's a lot of advocacy. Okay. In other parts of the world, the government comes in to support their treatments. So governments are the one procuring these replacement factors and using it to support their citizens. And for Africa, we are far behind our governments doing that. So the World Federation of Haemophilia has come to fill in that gap with what they call the World Federation of Haemophilia Humanitarian Aid Organization. Okay? So they support us with the factor concentrates that people with hemophilia in Nigeria can access free of charge. Okay, and that's been going on for close to 15 years now. So we've gotten that support. But we need to identify and recognize those that are yet to present. We're using it to diagnose. And the federal government of Nigeria is beginning to pay attention to hemophilia. So in 2023, we now have the bleeding disorders in the national policy on non-communicable diseases. Okay, they are about to complete the national guideline on the treatments for bleeding disorders, hemophilia and bleeding disorders. So they are beginning to take those tiny steps to support people with hemophilia. And I believe over the next few decades, things will also change significantly.
Okay. Wow.
So treatment is expensive, but it's available. We need to identify people with hemophilia and get them into treatment programs.
Okay, so I'm still reeling from the amounts of money, but the fact is It's available.
It's available.
It's available.
With support from the World Federation of Haemophilia and Humanitarian Aid, and the federal government of Nigeria is also promising to start to support.
All right. So, then the next question for me is, yes, because you said you practiced for decades. So in the last 15 years, you've seen the support, and that means the quality of care, the quality for our patients with hemophilia has greatly improved.
Greatly improved. I can attest to that.
Yeah. So, what does the future look like?
Even better.
For hemophilia care in Nigeria.
Even better. 15 years ago, we didn't have factor concentrate. So when they present, we have to treat them with whole blood. The response is usually poor. The risk of a large volume transfusion is significant. And you can't use blood transfusion to do prophylaxis. So they'll develop all those chronic complications, chronic joint disease, and live lives of disability.
So for our audience that don't know what whole blood is, when you say you and you tell them what's right.
So whole blood is you take blood from the donor, everything is complete in that blood. You've not separated or taken out anything from that blood. You just give it to them, and you have to give it to them fresh. So we use fresh whole blood. So that means you collect the blood from the donor, intact, whole, you transfuse it to a known hemophilia within a few hours. Because the longer is delayed, the longer those missing factors that you want to use to replace, in them, also starts to decay in those blood. So we have to use fresh whole blood. And with fresh whole blood means that you have not given enough time to ensure that it is well screened. So the blood is not screened. It's a large volume. So a lot of complications with whole blood transfusion comes in. And also with whole blood, you can't use it for prophylaxis. So we have said this person lacks factor 8. Standard of care now is give him the missing factor so that it does not bleed. If you want to use whole blood, are you going to be telling them to come to the hospital 3 times a week, collect blood from a donor and give it to them? It's just not practical. Okay? Good enough. World Federation of Haemophilia supporting us with factor concentrates, recombinants, safer, more effective, and so on. And we'll be using that. And we are now putting our patients on prophylaxis so that they don't bleed and develop those chronic joint diseases and other organ complications. So they can live a normal life, go to school, the fear of bleeds or the fear of death, it's reduced. Yeah.
So what should family and communities that have people living with hemophilia amongst them do with family members? You've talked about the fact that yes, we have prophylaxis. So family that have children who have hemophilia, adults, what can they do to support the individual? And if you're in your community and you suspect it, what can they do?
So we've talked about those symptoms of hemophilia, those red flags. We want people to stop dismissing those red flags. So when you see a child who is crawling and is developing bruises and swollen joints, please refer to be screened. And the screening is simple. You just need to get the doctor to say, I want to do PT, not pregnancy tests, PT tests, prothrombin time tests, and APTT. Those are the 2 screening tests. We'll look at them, we'll be able to say, oh, there's a very strong, this suspicion is being confirmed, and then we'll confirm with a factor assay. So we want people to start paying attention to those red flags, okay, and refer people. And because it's, as I said, it's mostly inherited, so it's in the family. So you have a family member who appears to have signs and symptoms of a bleeding disorder, get the other family members screened. Get them screened with a PT test and a PTTK or APTT test. Get them screened. Let the doctor look at that result, interpret it, and say, oh, this suspicion is being confirmed here. Go for further evaluation so that we can all take preventive care and prevent those disabilities. The consequences of untreated hemophilia is devastating. We see it when they present late, and it is devastating.
All right. So you mentioned the tertiary hospitals. Do we have tertiary hospitals in all 6 geopolitical zones, or most of them are concentrated that have treatment centers in certain areas?
Yeah, so I think the Hemophilia Foundation of Nigeria has tried to make sure that we have a good geopolitical spread. Okay, you find them in the northeast, northwest, north central, south, southeast. You find in at least 1 or 2 tertiary hospitals in this geopolitical zone, and they are also making a lot of effort to have a treatment center in every state capital. So those are the efforts that are being made, and I believe over time we'll get there. We'll be walking, snail pace, but we'll get there. We are not where we have 15 years ago. We may be too slow, but those efforts are being made.
It's better to go forward
than not to do anything at all. Like that.
Yeah, than not to do anything at all. And that's so important for our audience, because then they know that you don't have to come all the way to Lagos. If you do your research within your locality, you're bound to find one, if not in your state, in a neighboring.
You don't even need to come to this tertiary hospital to get trained.
Yeah.
If you see those signs and symptoms, go to a good laboratory and get those tests done. The PT and the PTT.
Yeah.
A PTTK test. If you do those tests done, it will confirm the symptoms, the signs and symptoms you are seeing. And then once it's confirmed, then you now need to get to one of these hemophilia treatment center to get registered, so that you can be in a treatment program to prevent those complications.
All right. So, Professor Adeyemo, as we wrap up, it's been a very, very insightful conversation. But as we wrap up, we're going to play a little game, myth or fact, to sort of dispel some of the myths that people have about hemophilia. You dispelled one, but we'll start with that. Only males have hemophilia, myth or fact?
Myth. Females do.
Hemophilia always shows up at birth, myth or fact?
Always shows up at birth. I would say that is a myth, because some people are presenting for the mild phenotypes. They may present later when they get a dental procedure or they get a traumatic challenge. So not necessarily at birth.
Okay. People with hemophilia should avoid all physical activity, myth or fact?
That's also a myth, because if you don't get physical activity, you're going to get weak muscles. And weak muscles increases the risk of joint bleeds. So we want them to engage in supervised, controlled activities like swimming, for example. It's safe for them.
Okay.
But no contact sports, no football, no rugby, no baseball. Those are really dangerous sports. Yeah, but we do want them to walk around, do some physical activities so that they have strong muscles to reduce joint bleeds.
Okay. Early diagnosis improves quality of life and prevents complications.
Facts. There's no doubt about that. Said it. Don't get diagnosed. You don't get treated.
People with mild hemophilia may never know they have it. Myth or fact?
I would say it's a fact. If they are lucky not to get challenged, they're lucky not to have a tooth extraction or to have a surgery, then they get away with it. Yeah.
And finally, we all know what this is, but finally, because we know that this is Nigeria, we are very religious people, hemophilia is not contagious.
Facts. Facts.
So
it's not contagious. It is a medical condition. It is treatable.
Okay, so if you see a child that bleeds, an adult that's bleeding, don't hesitate to help, because that person can be helped at any of the hemophilia treatment centers. Do you have any last words for us?
Yes, I do. There's a need to close that gap and diagnose that child, that woman, that girl child, that woman who may have a bleeding disorder. That girl who is having heavy menstrual blood flow should not be dismissed as normal. It may be a bleeding disorder, and we need to diagnose. We need to recognize to prevent a future postpartum hemorrhage.